this introduction to patient public involvement. My name's Andy Gibson. I'm an associate professor in public involvement uh, based at the University of West England. And I also lead a team of people called the People in Health West of England PPI network. It links a lot of researchers in both UE and University of Bristol and working in various other organisations like Bristol Health Partners, the Health Protection Research Unit, the BRC Biomedical Research Collaboration in Bristol. I won't go through them all because you'll get bored with the alphabet soup. Um, we've got a a team helping us present today, so we'll just go through the team. So, Pfizer, do you want to introduce yourself?
Hi everyone. My name is Faiza Gul, and I'm an associate research associate in public involvement, and I'm working at my essentially my role is to support researchers and academics to embed public involvement and engagement element into their projects and in their research work. Thank you very much. Nice to meet you all.
Hello, I'm Catherine Brown. I'm the project coordinator for People in Health West of England. I'm based at the University of Bristol as part of the partnership, and I will be the person doing slides in the background and doing a bits of technological problems if anybody encounters any of those. So if you have anything to point out to me, please pop it in the chat.
Great, thank you, Kathy. And Adele?
Hello, everyone. My name's Adele Webb. I've been a public contributor since 2013. I came into this as a carer 2 times over, and I joined the strategy group of People in Health West of England, and that set the scene for all that's to follow. Since then, I've been sort of member of advisory groups, steering groups, funding panel, and also participant on various studies, and in a variety of fields, which will come up later.
Great, thank you. And other Kathy? Kathy Cantor. There, Kathy?
Good morning. Compared to Adele, I'm a newbie. I've only been doing work as a public contributor for the last couple of years, and I'm delighted to be here today where we'll talk a little bit about our experience of that. Thank you.
Thanks, Kathy. Yeah, please feel free to ask questions, or if you want to say something, you can stick your hand up, or and we'd rather there be conversation rather than it just been us talking, or you can use, as Kathy said, the Q&A. So yeah, please do ask questions. Please do interrupt if there's something that we've said you don't understand or you want to say something about. But yeah, but we'll crack on. So if we go to the next slide, please, Kathy. And sorry, yeah, you do get copies of the slides. So Faiza's going to kick us off with this first slide, I think.
Yeah, so public involvement in research is something about working with people, not doing research to them. It recognizes that people with lived experience bring insights that strengthens the quality, relevance, and the impact of research. And for this purpose, many terms are used to talk about engaging and involving the people and public with research. And these terms are often used depending on your discipline or funder and the nature of the engagement. So the involvement means where people are actively shaping the research itself. Public contributors help decide what gets researched, how it is designed, and how the findings are shared. So this is a collaboration. People are partners, they are not participants. For example, reviewing proposals or designing methods and sitting in advisory groups. Engagement is something about sharing information and opening dialogue. It's when the researchers communicate with the public to raise awareness, build understanding, or spark some interest. And public are not influencing decisions here, but they are being informed and invited into the conversations. For instance, public talks and social media updates and science festivals, for instance. And the participation is when people take part in the research as study subjects. They contribute data, experiences, or samples, but they do not shape the research design. Essentially, for example, completing surveys and joining clinical trials and being interviewed. These terms are often used interchangeably, but they describe very different roles. And being clear on this terminology is, helps set expectations and ensure ethical practices and supports meaningful involvement rather than tokenism.
Yeah.
Over to you, Andy.
Yeah, thank you. So thank you, Faiza. And then one of the other things that people sometimes find confusing is when is something patient and public involvement or when is it qualitative research? I think that particularly comes up where some researchers might be thinking, should I be running a group interview, like a focus group or something, or should I be running a PPI, a patient to public involvement workshop? And on the face of it, the two things can look very similar. But what this little table does is gives you a little checklist so that you can kind of check whether what you want to do should be properly seen as qualitative research or should be properly seen as patient and public involvement or a patient and public involvement workshop. And in this has some practical implications because if you're doing research on someone, if you're a research participant, as Faiza's just described, then you should actually be getting ethical approval, research ethics approval for that. But you don't need research ethics approval to do patient and public involvement, and we'll talk a little bit more about that as we go along. But this little table, I won't go through it all, and you'll get these slides anyway afterwards, but I will pick out some of the key things just so that people can get an idea of what it's about. So the first thing is when you're doing a qualitative research interview or group interview, usually you've already got a research question of some kind or something that you want to find information about, and you're conducting the interview or the focus group or whatever to find evidence, to find information that can help you answer that question. When it comes to involvement when it comes to patient and public involvement, usually actually you haven't got a research question as such. You might be working with people to say, is this the right research question, or help you to design the research question.
That's okay. It's better actually because I then
somebody's I think somebody's not muted.
It's me. Sorry.
It's okay. So the second thing I was going to say is if you're doing a qualitative research group interview, you'll probably be conducting the interview in line with some kind of methodology, and that might be grounded theory or realist evaluation or a number of approaches. When we design a public involvement workshop, we're not really governed by those kinds of sort of methodological and theoretical considerations. Our main consideration when designing a PPI workshop is actually to make it as accessible as possible based on the needs of the people you want to talk to. And that might include physical accessibility, making arrangements so that if people have got a sensory impairment, they can fully participate, being conscious of how neurodiversity might impact on the workshop, how it might be easier to access if you're a single parent, so you hold it at particular times and venues and so on. Those are the main governing things rather than some kind of theoretical methodology. And also, when you think about the results, when you do qualitative research, you record things verbatim and then you subject them to some form of analysis. So it might be some kind of inductive thematic analysis or deductive analysis. With a patient and public workshop, we do record what people say, but it's more like recording minutes of a meeting and actions and decisions. We don't go beyond recording what's discussed in the meeting and the suggestions that are made. We certainly don't subject it to some kind of uh, analysis. So, and then finally, when we write it up, you can publish both these things. Um, but you can publish them in different kinds of journals. There are qualitative journals and PPI journals. So you tend to publish perhaps in different places. But the key thing is as I mentioned, it's in the slide, is that if you're doing qualitative research, you don't need research ethics approval, which is what you do need. If you're doing qualitative research, you don't need ethical approval for PPI. So obviously, there's some grey areas, but if you go through that list and you find the majority of them are in the qualitative research project box, then that's probably what you're doing. And if you're ticking most of the things in the right-hand box there, then you're probably doing public involvement. And they do, as I hope is clear, do different things. And as far as I said, it's about helping people. If they're helping you design the research and run the research, then it's very different things to them being the research participants. I'll just pause that. Does anybody have any questions about that, or is that clear to everybody? Oh, I can see a thumbs up. Yeah, a couple of thumbs up. Great, thank you. Great. Well, we'll move on to the next slide then. So, back one slide, please. Oh, which slide did we go to? Yeah, so that's right. Okay, sorry, we jumped about a bit. So the other thing I was going to say is why do we involve patients in the first place? Well, obviously, many funders now make it compulsory requirement. NIHR, National Institute for Health Research, make it compulsory that you've got to show that you've had public involvement in designing your bid and a plan for how you'll involve people when you're carrying out research after the event. And this is also true of funders like Wellcome. Though Wellcome use slightly different terminology. The definitions that we were looking at that Pfizer talked us through come from NIHR. As Pfizer said, different funds have slightly different terminology. Wellcome would use the term engaged research to cover all three of those things, but nevertheless, they would like some evidence of something along the lines that we've been discussing in your bid and how you would do it going forwards. But hopefully that's not the only reason why we do this, i.e. to get grant money. I mean, and you might be thinking, what's the purpose of this train? And is it something to do with my holiday photographs, which it's not actually, but it's to make a point that if you think about the people who sat on that train, some people will look out of one side of that carriage where they're seated, and they'll see the side of a mountain. And some people on the other side of the carriage will look out of the opposite window and they'll see a valley. So when asked to describe the journey, one might say the train went past a valley, and the other one might say the train passed a mountain, and they're opposite to each other. But clearly, you can't say that one perspective is wrong and one perspective is right. They're both complementary. It's just that different people have got a different perspective, and you can take it further by saying, some people are facing forwards and some people are facing backwards. When we do research, particularly health research, where we're wanting to improve people's well-being, the science side of it is obviously very important, but it's not sufficient in itself. We need to understand what matters to the people, members of the public, patients, carers, whatever, what is important from their perspective. And crucially, if there are interventions that we design in, that these are actually workable in the real world. And an obvious example that's attracting interest at the moment is vaccinations. And we know that there are social reasons why some people are more hesitant about vaccinations than others. And one of the ways of trying to build strategies to cope with that might be to run patient and public involvement. Um, so I think this is one of those things where it's ethically the right thing to do. But it also improves the quality of your research. Um, and just to say, because more than one perspective can be true, it doesn't mean to say all perspectives are true. I'm not kind of going down some relativist line here. If somebody said, I looked out the window and saw a flying pig, then that would clearly not be true. Um, so just because you accept that there are multiple perspectives and that they might complement each other, even if on the surface they appear to contradict each other, that just doesn't mean that therefore you have to agree with everything that everybody says, whether they be a public contributor or an academic, or for that matter, perhaps a professional who's been involved in delivering a service or care that you might be working with. So we need to maintain that critical edge. Next slide then, please. Oh, God, thank you. Someone's put the thumbs up. That does make sense. We touched on this earlier. Do we need research ethics approval for PPI? We don't, because we aren't carrying out research on people, and the primary purpose of research ethics approval is that potentially with research on people, you're exposing people to something that they wouldn't normally encounter in their daily life, and which might potentially do them some harm. Obviously, that's really obvious when you might be doing a clinical trial where you're testing a new drug or something like that. But it would also be true if you may be testing whether how you might reorganize and deliver a service, or a new type of psychological therapy for someone with depression or whatever. So there's always a danger that the research ethics there is there to make sure that the patients or the participants are kept safe. In PPI, we aren't doing that. They're helping us design the research. So that's why they're part of the team. We should think of them as part of the team. So we don't go to get ethical approval to do PPI from a research ethics committee. But does that mean that PPI doesn't raise ethical questions? Well, obviously that's not true. One of the things that we do a lot in PPI is, in particular, try and reach out to underserved communities and reach across health inequalities to involve people in research, and that involves a whole range of ethical questions. I'm currently involved in a project which is an evidence synthesis project, which is a project that's bringing the evidence together on a particular question to help inform NHS policy, and it's on the pros and cons of different forms of treatment and support for transgender people. Now, you can imagine that raises lots of questions, difficult questions, sensitive questions, ethical questions about how we might work with those group of people and do it properly and support them and deal with the very contrary points of view. And some of this debate, as you'll know, is very toxic. So doing this well does raise ethical questions. So we're not in any way saying that it doesn't raise ethical questions. We're just saying that the appropriate governance for that and the way of dealing with it is not through a research ethics committee. And if we move to the next slide, so it may not be research ethics that we're interested in here, but we may be interested in something that's called relational ethics. So relational ethics emphasize the importance of relationships in decision making, and it is about respect and reciprocity and engagement with different perspectives. So it fits in with that slightly philosophical thing that we just touched earlier. But also there are things that you can learn more about, like trauma-informed practices and ways of working with people. And I think that both Kathy and Adele are going to perhaps give us some observations on this from their point of view as public contributors. Adele, do you want to go first?
Yeah, I've just got just some observations on my experience, and basically I was thinking about it, and I've just had overridingly positive experiences of all of this in terms of
Great, thank you. No, it is Adele. And Kathy
Just
Campton.
wanted to give two quick examples of where there may be differences of opinion. Recently, with two other public contributors, we looked at the expressions of interest submitted by research teams for the next iteration of the Biomedical Research Centre. And interestingly, the views and the rankings of the public contributors were not only different from the academic, the clinicians, but sometimes diametrically opposed. And this was quite difficult. But we put our points of view as clearly as we could and with great respect. And in fact, they then treated us respectfully and agreed to go back to those teams that they had scored lowly to ask them to resubmit their applications and to give them some support to do that. And that was very satisfying. I thought it was handled well. And the other example I wanted to give is with my PPI colleague Jo, who's with us on the session today. We're on the senior management group for the Bristol Clinical Research Facility, where studies are considered for approval for use of the facility or the staff. It's quite a high-level meeting. It feels a bit niche, but Jo and I speak at every meeting and we ask questions. However, we're very aware that the questions we ask are not at all the questions that the other group members might ask. And yet we are treated with respect and we're taken seriously. Our questions are answered and explored. And I think we both feel they can see we're doing our best and they do their very best to make it easy for us. Thank you.
Great, thank you, Kath. They're great examples. And Jamie, by the way, I've seen your question about can I say something more about publishing with PPI. So we'll say that when if we haven't touched on it before, we'll definitely come back to that at the end of the session. I just wanted to say, just before we go on to the rate waste research, just about the relational ethics bit, I think also we have to context really matters. So I think particularly at the moment, if you're working with communities, particularly from global majority communities, we have to be aware that the context around us at the moment, the political context, is very difficult. We all watch the news. We've all probably seen streets full of Union Jacks at various places, which can make some people feel very alienated and unwelcome. So I think it's always worth, as well as these general principles in relational ethics, just to think about actually what's the context, what's happening politically around us that might be impacting on some communities in a particularly adverse way, and just being sensitive to that. Is everybody happy with this idea of relational ethics as opposed to research ethics as being the relevant thing for PPI? People can just stick some thumbs up if that's okay. Oh, great, thank you. Great. Oh, there's a hand up. Who's that? It disappeared again.
I think it was a thumbs
Oh,
up.
thumbs up.
It was thumbs up in the wrong way. Yeah, sorry.
That's okay. Great. So yeah, let's move on to the next slide then. Thanks. The other thing about research is what's called waste research. And this is quite an old paper now. You can see it's 2009, but it's actually a classic paper and it's been had a very big impact. Ian Chalmers and Paul Glazier are some founders of something called evidence-based medicine. Surprisingly enough, it was a surprise to me. I always thought till I got involved in this game that health and medicine was based on research evidence, but it's only in the 1990s that the term evidence-based health first appears. Before that, people were learning from the person who was in the job before them. It was the kind of watch one, do one, teach one philosophy. And we could go, there's a whole discussion there about things that might have been done that were at best pointless and at worst harmful. And then this development of saying, let's take a more evidence-based approach to these things. But also what Ian Chalmers and Paul Glazier point out, that a lot of work research, it's not just about doing research, it has to be research that adds value. And they defined waste research as research which people do, and we're talking particularly about health, and it gets published in journals, but if it doesn't contribute to improving the health and well-being of patients or the public, or it doesn't improve the way healthcare services are provided, then it's waste research. And they estimated in this article that something like 90% of research was waste research following that definition. And that you can follow, they've subsequently published follow-up papers that update this one in a more modern context and found that although some of this problem has been reduced, it's still a prevalent problem. But one of the things that they recommend to reduce waste research is co-producing the research with the people it's meant to benefit. So we've touched on this already, but not just asking a question that's interesting because it's interesting to an academic, but actually asking either the people who deliver the care or the people who receive it what they think is important. And again, when we're designing interventions and things, designing the things that actually are going to work in real life, as opposed to the artificial experimental circumstances of a clinical trial. And again, picking outcome measures that really matter to people, rather than something that's just relatively easy to, say, measure and put a number on, which might look very scientific, but might not have that much real world evidence. Adele, I know you've had some thoughts about this and you've talked about it from a patient's perspective. Do you want to add anything to this bit?
Really, just to support what you said, but I've got down just the things that have become important, and the key questions are what matters to patients and the public, which is, over my years of experience, has become really, really strong and focused. The second thing is what difference will it make? What actual difference will it make? And then lastly, that the emphasis isn't just on academic papers, on those other two things, the difference and whether it matters. And that's what I've found sort of on the practical side of projects. So I agree with everything you said.
Great, thank you, Adele. Shall we have the next slide then, please? So I think Pfizer's going to talk to us about the UK standards for public involvement.
Yeah, thank you. So UK standards for public involvement in research provide a clear framework for what good public involvement looks like, helping us create research that is more inclusive, transparent, and genuinely shaped by the people it aims to serve. So inclusive opportunities is the standard. This standard is about making sure involvement is genuinely accessible. So it's more thinking about who needs to be in the room and whether our opportunities reach them. That means that considering barriers, practical, cultural or structural barriers, and designing involvement so people can take part meaningfully. So working together, the focus here is on relationships. Effective involvement always depends on trust, respect, and valuing everyone's contribution. And it's about creating a space where power is shared and decisions are transparent, and contributors feel their expertise are recognized. In terms of sport and learning, people can only contribute well if they feel confident and prepared. This standard reminds us to offer the right support, whether that is training, maybe briefing materials, or simply checking in. It's about enabling both researchers and public contributors to grow their skills. Communication is the key. Clear, timely communication underpins everything. It's worth, thinking about using plain language, avoid jargons, and keep people informed throughout the project. Good communication helps contributors understand their role and see how their input is shaping the research. Impact is about understanding and demonstrating the difference involvement makes. So, you capture what has changed, what has improved, and what we have learned. So sharing impact helps building accountability and strengthens the case for meaningful involvement. And finally, the governance ensures involvement is embedded at every level. It means that involving the people, not just in activities, but in leadership, decision making, and oversight. This also helps making involvement a core part of how research is designed and delivered, not as a add-on thing. So over to you, Andy.
Great, thank you. And one of the things here is about inclusive research opportunities, and that's something that's become very important. So if you go to the next slide. So the NIHR call this research inclusion, and it's about making sure that that research in all its aspects doesn't just include white middle class people. And that's been true both of the research workforce and the people who've been research participants, the people that the research has actually been done on. And it's also been true of patient and public involvement. So research inclusion covers all those three aspects. Obviously, today we're going to talk mostly about research inclusion in terms of PPIE, patient and public involvement and engagement. But the NIHR have really shifted their position on this, because prior to November 2024, research inclusion was something that was an expectation, and it certainly would have got you extra marks for having done it well in terms of any bid. But since November 24, it's now mandatory. So they expect you to address it, and they expect you to address it across all three fields: employment, how you're going to make sure that the participants are diverse, and also how you would do your PPI. And it has to be costed with a proper budget to do it, and it's formally assessed by reviewers, and they do monitor it afterwards. And why is this important? I just want to give you one example of why this is important. People may be aware of the device that you sometimes use to test the oxygen levels in your bloodstream. You slip it on your finger, oximetry test, and it shines a light through your finger, and dependent on that, how much light travels through your finger, it works out how much oxygen is in your blood. That the research that underpins that was done several decades ago. But what's only come to light in recent years is that device underestimates the numbers of people who've got low oxygen levels if their skin's got a darker pigmentation. That's only just been discovered. We don't know how many people have been misdiagnosed as a result of that. But it's because the original research was only done on people with light skins. So it just shows you how it's ethically the wrong thing to do. But it also undermines the scientific rigor and value of your research, and obviously having a more diverse group of public contributors contributing to your PPI groups maybe would help you spot issues like that and design your research in a way to avoid that sort of thing happening. So it's an important thing. And what we'll talk about is some practical ways of addressing this. So next slide, please, Kathy. So one of the things that we've done locally is set up this thing called research ambassadors. So research ambassadors are people who are recruited from particular underserved communities in their proper paid jobs. They're managed and employed by AFI Health, which is an organisation, a voluntary organisation, a charitable organisation based here in Bristol. But as I say, the research ambassadors are people that are in proper employed jobs. They get training and they get monthly pay and so on and so forth. And they get and basically they act as a go-between, a two-way communication channel between a particular underserved community that they've been recruited from and researchers. So it's partly, I can remember once talking to somebody and someone said to me, Andy, if you go down to the Malcolm X Centre and organise a meeting to talk to people from the Afro-Caribbean community and stick leaflets up, nobody will turn up or hardly anybody will turn up. But if I organise it as somebody who's part of that community, a lot more people will come because I've got some trust within that community. And it's really about building that, recognise that's a really important issue. And to do it properly, we need to have a proper infrastructure for coping with it. The other thing that we try to do with the ambassadors is to make sure that one particular community doesn't get bombarded with requests from researchers from all angles. Actually, if we can manage it a little bit better, then it'll stop some of those communities getting overwhelmed. But also, there are other communities that might get missed. And also the other thing is to give back to the community. We can say that research will give back to the community, and that's why people should be involved. But we all know that sometimes that doesn't happen. And if it does happen, it could be several years down the road. But what we've tried to build into this model is, we're creating proper employment opportunities for people from underserved communities. But the workshops we run, we always make sure that there's something there that will benefit people there. That's built into it. So some of the workshops we've done, we've made sure that there are healthcare professionals there to do things like blood tests or blood pressure tests or kidney function tests, so that there's a give back straight away. And I'll just touch on the Barton Hill Coffee Morning. So Barton Hill is in a very deprived area of Bristol. It's I think it's in the top 10 of deprived areas in the country. It's got high different ethnicities, but these are very informal coffee mornings where researchers can go in and talk to people in a morning over a cup of coffee. So very informal, but it's a great way to meet people and talk to people. And it is very informal. I did one about a particular issue, and about halfway through, this little boy who'd come with his mum was sick and threw up because he'd eaten too many chocolate biscuits. I'm only telling you that story just to get you a feel of, it's very informal, but I think you'd get feedback in that forum in a way that you wouldn't get from elsewhere. But if you're interested in pursuing those or some of the other things that we've got, then please email Mary Rose Kennedy. I can see her email address there. But this is just one of the ways that in practical terms, we're trying to take forward this research inclusion thing and make it easier for researchers to do, but also make it easier for people from those underserved communities to become involved. So yeah, should we move on to the next slide, please? So changing topic a little bit now. But one of the things is important both for your funders and for the academics, but also crucially for the members of the public you're working with, is understanding if all this time and effort is making a difference and it's having an impact. And there's quite a lot of literature on evaluating the impact of PPI, and actually we've got a whole workshop on this. That we're going to be doing later in this series. So I'm not going to go into all the detail about it, but I think it is just worth touching on here. And there's a range of tools for doing it, but this is one of the simpler things that we've developed, which is just simply an impact log. And as you can see, you've got a date for, say, when a meeting or a workshop happened, the name of the project, type of involvement. Yeah, so was it a workshop? Was it an advisory group meeting? Or was it some other kind of involvement? Who took part? So members of the public, which members of the public, researchers, etc. The outcome might be the immediate decisions or things that were made, but the impact might take a little bit longer. So the outcome might be, let's rewrite the information sheet for a piece of research. The impact might be better recruitment. So that might happen a bit later on. And then there's also reflections and learning. And these things can be filled in by researchers and members of the public. And also record where maybe ideas get brought up, but for one reason or another, I can't be taken forwards, either because somebody thinks it's a bad idea or perhaps because we don't have the resources to do it. So these are hopefully quick things to do. Shouldn't take lots of time to do them. But Adele's been involved in use of these, and she's going to just talk us through an example. So I'll hand over to Adele.
Thank you. Yeah, this example was used to capture the impact of PPI during the implementation stage of Don't Wait to Anticoagulate, which was an atrial fibrillation intervention that was being rolled out across Gloucestershire. I found it easy to use, not too onerous and not too daunting. I'm going to concentrate on the last three columns from a public contributor perspective. Initially, I struggled with the difference between outcomes and impact because I come from a school background and outcome had a slightly different interpretation. So it was really helpful and it was sorted out very quickly once my PPI lead explained that outcomes were short-term and impact was long-term. However, it became apparent that public contributors are not always party to the long-term impact of their involvement or the changing picture. So a consistently open channel with the team was a really helpful and positive measure. It benefited both researchers and public contributors. It was the learning column that I found really valuable. Initially, I was concerned that I should have only focused on learning from the research itself, but in conversation, I was helped to appreciate that the learning was valuable on three levels. So the first level was a personal level. As you can see at the top of the end column on reflections, I was having trouble with acronyms, and that was really easily sorted, quickly sorted with the help of the PPI lead. Secondly, there was learning on an organisational level, and in this case, across Gloucestershire, practice changed during annual health checks. So if you can have it just underneath the acronym bit, it says the importance of pulse rhythms in checks. Originally, it just, when I was having my data gathered and everything, they didn't register the pulse checks. But during this, the practice changed during the annual health my annual health checks. And when my blood pressure was taken, the pulse rate was now monitored and recorded. So that had taken place across the county. I experienced this change of practice when I went for my own annual health check and was delighted to see that, what had been learnt from the project. Thirdly, the project learned that the earlier PPI was involved, the better. If you could just switch to the next slide, Kathy, please. And if you look at let me just have a look. Yeah, down at the bottom, the last part of the learning. The project learned that the earlier PPI was involved, the better. Public contributors had not been involved at the developmental stage of the project plan. They would have recommended the capturing of patient feedback in initial primary care training in order to increase the disappointing response for evaluation purposes. So this was a helpful piece of learning because we helped to train the next CCG, as it was then, to take on the intervention, and they learned from our experience. I found this a really informative and positive part of the process, but it would not be effective in isolation. You need a consistent conversation between researchers and public contributors. It's essential. Thanks, Andy.
Great, thank you, Adele. I'll just pause there. Has anybody got any questions about that or any thoughts? Doesn't look like there are. Obviously, you've got the Q&A if you want to chat to put things in if you want to. So I think now we're going to talk a little bit more about just the practicalities of getting the job done, and Faiza's going to take us through this one.
Thank you, Andy. So when we talk about practicalities, we are really asking a question that how do we actually do public involvement in a way that works. It's less about perfection and more about being intentional, prepared, and respectful for people's times and experiences. So there is no single right or best model for this. What matters is choosing an approach that fits your project and the people you want to involve. So it's worth thinking about starting with small, clear, small group, and be clear about the roles and making sure that the contributors understand how their input will shape the research. A simple advisory group or one-off workshop can be enough if it's well planned. So when it comes to the recruitment, it's worth thinking about who you need and why. Go beyond the usual networks, like community groups, charity groups, lived experience organizations, and existing PPIE panels. They can all help you reach the right voices. But the key is that be transparent about expectations, time commitments, and most importantly, payment for the outset. So choosing spaces that feel safe is really important. That the places where you wanted to meet the public contributors are accessible and safe. Community venues often work better than the clinical or academic settings. And don't forget virtual options as well. They can widen access, but they also need thoughtful facilitation. Communication, as I said earlier, is the key. So clear communication, which is jargon-free, is essential. And another important thing is setting expectations early is really important. Keeping people updated and close the loop by showing how their input influenced the work. This builds trust and avoids tokenism. In terms of planning and budgeting, meaningful involvement needs resourcing and budget for contributors, payments, their travel, their childcare, room hire, and facilitation time. So planning early prevents last-minute barriers and signals that you value people's contributions. Next slide, please, Kathy. So meetings and plannings, guidelines and expectations and behavior. When we bring people together, the meeting itself becomes part of the involvement experience. So good planning matters. So be clear on the purpose of the meeting, what decisions will be made, and what you need from the contributors. Setting simple guidelines would help. That how we speak to each other, how we handle disagreements, and how we make sure that every voice is heard. So being explicit about expectations, time commitments, preparation, and what will happen after the meeting is really key element in this sense. And finally, model the behavior you wanted to see, like respect, openness, and genuine curiosity. Feedback and evaluation is important, as Andy said earlier. It is important to know that how did everyone do. Feedback is not an add-on thing. It's how we learn. It's worth asking contributors what has worked, what did not work, and whether they felt their input made a difference. And it's also worth reflecting on your own practice too. Did you create space for meaningful involvement? And worth asking that were there barriers you did not anticipate? So that will help you, you know, in the future events where you can do a much better practice. Working with young people requires flexibility and creativity. So it's best to use formats that feel natural to them. Arrange shorter sessions, for example, interactive activities and visual tools, which the young people are more interested, will be more engaging and more inclusive, and be mindful of safeguarding too, and the power dynamics. And most importantly, treat their insights as expertise, not nice extras. So young people often spot issues which adults often miss. The pandemic has changed how we involve people. We have other options like hybrid and online approaches, and these approaches can widen access, but they also introduce digital barriers and fatigue. So think about choice, that some people prefer in-person connection, others need remote options. And remember, well-being, pace, accessibility, and emotional safety matter more than ever. Next slide, please. Thank you. So co-production or public involvement is not limited to the start of the project. It is a flexible, ongoing opportunity, and meaningful involvement can still happen at later stages, whether refining methods, sense-checking findings, or shaping how results are shared. You can see this diagram is produced by Louis Ting, a public contributor for the NIHR Applied Research Collaborative. And this diagram reminds us that the co-production is not a single moment. It is a mindset. It's a continuous opportunity. While early involvement prevents tokenism, but it's never too late to bring people in thoughtfully, as long as their contribution genuinely influences the work. We often think about dissemination, public contribution at dissemination stage, or reviewing advertising materials, or information sheets, but public can contribute and have an impact on your research at any stage in this cycle. You could involve public contributors at just one stage or multiple stages, depending on your research project aims and objectives. But it's never too late if it's not something you have thought about before. You can still involve the public at later stages, whether we are designing the study or
Isaac, you've muted yourself, I think, by accident.
where did I do that?
Only
At what
just, you
point?
only just
Okay.
did that.
Okay. I think I've completed. And just like the diagram shows that their input can shape each and every step in this cycle. So yeah,
Great.
over to you, Andy. Thank you very much.
Thank you, Pfizer. And I think, Adele, you're going to give us some examples from your perspective as a public contributor.
Thank you. Yes, I've picked out some more unusual ones. At the beginning, when I started out on this journey, it was largely being on advisory panels, and if I'm honest, it was very often being presented with something that had already been shaped, comment on it, but largely just to approve it and send it through. And that's changed over the years. So the one that is the major difference for me was at the top of the identifying topics for research. And I served for 5 years on the funding an NIHR funding panel, and that I started with sorry, I've lost my screen for a minute, and I don't. Can you hear me?
Yes, we can hear you.
Oh,
Yeah.
that's right. I've got the screen back again. Sorry. Yes. So identifying topics for research. The NIHR committee, they asked for proposals for future topics for future commissioned calls. And I suggested what happens after a diagnosis of dementia in terms of support, largely because of the experience of my friends and family in different parts of the country. And that was a big thing. Do I apply for this? Do I put myself out there? And I did it. They made it very easy, a very, very just one page to just put your proposal forward. It wasn't too academic or frightening, and it was actually taken forward. And I'm now part of LiveDem, which is that they're shaping a course for people living with dementia, and also extended to family members. So I've sort of gone through the whole journey of that, which is quite privileged. The second experience was to do with the design of a study, and that was with Ready, which was a project to look at the evaluation of paramedics in primary practice. And I never envisaged it would be possible. I thought it was far too academic, but actually I took part in the literature review stage of the project using a journaling technique. Now that really needed some support, but it was really enabling, and it for me it opened up. It didn't only use my previous skills, but it also opened up new doors. The support was very sensitive, but it was crucial, and I helped to clarify the research question. At the implementation stage, I took part in a longer term project, but it was mainstreaming genomic medicine, which I'll talk about later. But when the 100,000 Genome Project was complete, we helped to take genomic medicine and embed it into normal service. So that was a really big thing, as you will appreciate, with the impact of genomic medicine now. And then lastly, as I've talked about in the with the impact log, that's where my experience has been on evaluation. So it's sort of almost round the clock, so to speak, of the diagram. Thank you.
Thanks, Adele. That's really, really helpful. So as people can see, you can do public involvement throughout the research process from the beginning. If you're partway through a process, by the way, as Pfizer said, that doesn't mean say you can't start wherever you are, even if you've not managed to do it easier. So don't think just because you've not done it from the very beginning that somehow you can't do public involvement. But if we move on to the next slide, we've said that you can do this throughout the research cycle. This is a bit of work we did with the Biomedical Research Collaboration in Bristol, the BRC, where we did a survey of PPI activity across the BRC. And you can see, obviously, we want to be aware that some things might not have happened because they were planned, hadn't got to that phase. So you can see there that we've got both the completed PPI and planned PPI in that bar chart there. And you can see it's across different stages of the research cycle. But I think what you can probably clearly see is that there's a lot of PPI in the early stages, and that might be because it's compulsory for funding bids. So people are doing a lot of stuff around the design and question generation and things like that. Probably because they're doing that when they're writing the bid, and it's something you have to show. But if anything, I think as you go through that process, you can see that the PPI tends to tail off, and very few people are doing PPI and, for instance, analysing and interpreting data. There's two things to that. I think that some of that is about that people think that you can't meaningfully do that. So the researchers analyze the data, whether it's qualitative interview data or quantitative statistical type data, they do the analysis and then they present it to members of the public and they get to comment on it. But we've done work, and Adele was involved in a study which involved looking at what the impact of putting putting GPs into emergency departments was about. And we looked at ED departments across England. And when we looked at the impact of doing that, we used the results were presented in something called forest plots, which some of you may be familiar with as a way of showing statistical results. But we trained the public contributors to interpret those, and they came back with some really good ideas about what it meant. And also even with qualitative research, where we've taken sections of interview data and anonymized it and asked the public contributors to identify key themes and issues in the qualitative data and compared it with what the academics have come up with. So I think one of the things we wanted to do is develop resources to make sure that people feel that they can feel confident to do PPI in all bits of the research. Adele, I don't know if I didn't ask you this before, and so I'm just dropping this on you, but I don't know if you wanted to say anything about that experience with the forest plots and the.
Well, it's totally out of my comfort zone. But again, I hadn't been involved in sort of like data analysis before, but it was the support sessions. It didn't feel like training, but it just made it possible because they were hugely challenging, fascinating. And it was developing my skills as well as I hope helping the project, but it did also help us to, as you know, that you asked in the end what we thought about it as a use of public money, and it was doing that data analysis that really helped to help us make a judgment and a decision.
And it was really helpful because, interestingly enough, the results showed that it didn't make much of an impact. And I think it was the public contributors that were first to sort of say, look, this is sucking GPs out of primary care. It costs a lot of money to put the management structures in, and you've not got much impact. And I think you got there much more quicker than other people did in the project who are trying to look at small things and say, oh, well, there's an impact there. Look at that. Is that fair, Adele, do you think?
Yes, definitely. Because I felt it was, although it was like a negative, it felt like it was of the project, it felt like a negative judgment, but it was a hugely important one because we were thinking, in terms of our practice, if you're taking GPs away from practices that are already struggling, so it was listening to what we said and what we felt.
Yeah, and that was a key part of the recommendations that came out of that report.
Yeah.
Great, thank you.
Can I just, I don't know whether it's
Yeah.
politics for me, I put it in the chat, but was Kathy going to offer her experiences on Louise's diagram?
I think Kathy said she didn't want to actually, but
Oh,
anyway, sorry,
beg
Kathy.
your pardon, I'm out of the loop, sorry.
Is that all right, Kathy? I thought you'd said that you weren't going to contribute to that, but oh, you've got your thumbs up. That's all right then, fine. But I saw that in the chat as well. I thought, have I made a mistake there? So that's fine. I think Kathy is going to chair. Other Kathy is going to chair this session.
There's many Kathys. It gets a bit confusing. Sorry about that. So yes, I'm going to ask our two public contributors a few questions. So I will start with my namesake, who spells it with a K. Question 1, what motivated you to get involved in research?
Thank you. Well, the first time I was invited by a friend who was a public contributor to take part in a study where they were having trouble recruiting participants. And it was a study where they were looking for people who had experience of looking for people who were housebound. And they were seeking to find consensus over the definition of housebound, what that term means. For example, does it range from someone who's totally immobile at home and needs 24-hour carers, or does housebound mean someone who needs a taxi to go to the hairdressers once a week? So we had to do a 3-hour questionnaire on our own at home and then a 3-hour meeting to kind of thrash it out, if you like, and try to come up with a consensus. And after I'd done that, I then saw the advertisement for the public advisory group for the Bristol Research Centre and Clinical Research Facility. And that seemed to be something a little bit different than this one-off experience, with regular meetings, or in one case, monthly meetings. And I could see that the work that they were doing was really important. And so then I applied for that as well. Thank you.
Thank you, Kathy. And Adele, I will ask you the same question. What motivated you to get involved in research?
Initially, it was to offer lived experience to help make a difference. I was caring for 2 people and things were going a bit wrong with my local trust. And I got involved with them, and they then channeled me through to have a voice with people in Health West of England. So it was to help make a difference to what was going wrong a bit. But I've been a carer twice, and that's what I offered as a basic perspective. But since those early days, I've had an experience of a variety of emergency services. We've got a rare disease in the family, and dementia and end-of-life care have also become an added focus for me. Later on, I've wanted to contribute to areas where, as a family, we've appreciated the need for research, such as rare cancer. And
oh, sorry, Adele, you've gotten muted there in just a few seconds. Right after rare cancer.
Yeah. So now I've got a curiosity about research. The COVID experience helped us all to appreciate the impact of it. And life has taught me that it has a relevance to everybody's lives. And I'm ashamed to say I didn't appreciate that as a younger person. So my motivation has developed over the years.
Thank you both. Next question, I will stay with you, Adele, simply because I'm looking at you. Could you tell us about an involvement activity you have done and how you felt it has made a difference?
Yeah, as I mentioned, the one that I've been really proudest of was to be part of the 100,000 Genomes Project, which set out to gather 100,000 sets of whole genome sequences to form a reading library, which could be used by researchers in the context of rare diseases and certain cancers. I was a public contributor for rare diseases because of the family one, on the regional board for this. And when the project achieved its target, we then helped to embed genomics into normal service. For example, I had to wait 14 months for a genetic test. That wouldn't happen now, as referrals have been made more direct. So in my lifetime, I can see the difference this has made. Apart from more responsive and streamlined NHS pathways, I can see increased diagnosis and more personalised treatments in both fields. One thing that's really hit home is that in an early discussion group, we and I were asked for our perspective on a blood sample being taken at birth, then banked for reference during that person's life and health journey. This is now being offered to new parents for their child, and there is a significant uptake. And I've been privileged to see the difference that is happening.
Mm.
Thank you, Del. Fantastic. Kathy, I will address the same question to you, please. Tell us about an involvement activity that you have done and how you felt it has made a difference.
Well, the thing that I do that takes most time is being on the senior management or prioritisation group for the Bristol Clinical Research Facility, which is a purpose-built facility for medical research where they test new treatments. And some really amazing, interesting studies are brought before this group to see if they are able to go forward and if the facility can be used for that. And so there have been lots of studies on vaccines, but most especially malaria. And as PPI contributors, we were helped to understand the massive impact of malaria worldwide. Some hypertension, high blood pressure studies, pain stimuli studies, and cleft lip and palate in younger people, which is very impactful. And so the studies that go forward are all, what seems to me, very important work. And most recently, I've been invited to be a co-applicant on an emotional well-being project, which is in its infancy, but sounds very exciting. Thank you.
Thank you, Kathy. What an amazing range of projects you've both been involved in. It's really quite astonishing. Adele, I will address the next question to you, please. As you have been doing public involvement for a number of years, number to remain unconfirmed, how do you think it has moved on?
Well, PPI's definitely got a stronger voice. It's less tokenistic. We're not just being presented with something to approve. I think the overriding thing, from what I've said earlier, we'll see is that it comes in much earlier. And a good example of that is when I was on the funding panel, which was over 5 years. When I started with NIHR, I was on a committee just prioritising stage 1 proposals, which ones should go through to stage 2. This then developed further to assess stage 2 proposals for funding or not, decisions. Then we were asked to vote on a presented list of subjects for future commissioned calls. So we were being taken further back in the whole process. And then finally, we were asked to suggest topics for future commissioned calls, which I told you about. So that was, it really starkly says how much earlier PPI was coming in. As I've said, there's a much wider range of involvement opportunities. There is a greater focus, a really clear, strong focus on impact and implementation. And equality, diversity and inclusion has become a priority. And with NIHR, when you're getting to the stage 2, a reviewer will be dedicated to only look at that. And that was a massive step in the development for us, but also for NIHR. For the future, I just think more opportunities for community-generated projects would be good. It would be good to see it's developing, and I'd like to see how that goes, including serving all of the communities we've talked about, and also some of the underserved groups, such as people living with dementia, people with learning disabilities. There's just so much more to be done. Thank you.
Thanks, Adele. I'm going a bit off script here, but where would you suggest that people go in order to find out about these opportunities to become engaged with research? How did you find out about it? Was it social media, a newsletter, word of mouth? Is it a combination of everything?
Well, I was channeled originally by my hospital trust. People in Health West of England still is a major source for me, as you know.
Yes.
You have the newsletter that goes out, and that is reaching out, because I'm a dinosaur and I don't do social media. So it comes from there, sometimes word of mouth, but I think that's probably quite a limit, because I'm a dinosaur. That's quite limiting in terms of what other people do. But the word of mouth is also, it's very valuable. Yeah,
We protect our dinosaurs.
well, you also support them. But I would say PHWE, that newsletter, and because it's so wide reaching and it can be shared anywhere. So it's good.
And just to say on the newsletter, Kathy runs this, but I think it's fair to say there's like 450 people on that list, and that most days there's something goes out. Most weeks there's something goes out,
Yeah.
if not several
Yeah.
things a week. Is that right, both of you?
Yes.
Yeah, definitely. And it's
Yeah.
the variety as well. It's
Mm.
incredible.
Mm.
Well, that's a lovely plug for us. Thank you both.
Yeah.
It's genuine. It's genuine.
Thank you.
Fantastic. Well, as our reputation grows, we get a lot of opportunities coming in from people that I've never even heard of before. So it's very exciting times. So
Yeah,
hopefully
it
that
is.
momentum will keep
Mm.
going. Last question to you, Kathy. What have been the benefits and challenges of being involved in patient and public involvement?
Thank you. Well, I'm going to start with the challenges so that I end on the benefits. So I'm speaking personally here, and for me, there are several challenges, but the biggest is and always has been tech, tech, and tech. I am absolutely always the person who can't make their camera work or their microphone. And in some meetings, we talked about the chairperson and their important role. But in some meetings, people find it very hard to control their irritation with that. When I first came to PPI, I'd never even heard of Teams or Zoom. And the PPI facilitator, Eva, took me to her office and said, "This is Teams, this is what it does, this is how it works." And she showed me. And then the next week, she said, "I'm going to send you a link. You do a Teams call with me and we'll practice from home." And that kind of hand holding, I'm sure it's not necessary for most people, but for me, it's absolutely massive. So combined with, I greatly appreciate when meetings are opened early so that some of us who are unsure can just come on. This happened today for this meeting, and just check that you can see me and hear me, and I can see you and hear you. And that might sound infantile stuff. The other thing that was really helpful to me also with Eva back at the beginning, and she gave me her mobile number because I don't think I could cope with Teams on the screen and then having to message in Teams. And so I could WhatsApp her if I needed to on the side. And those things were immensely helpful to me. So tech is a massive challenge, and it requires patience and time and tolerance. The other thing that's been challenging is the fast pace of formal academic and clinical meetings. And it's really hard as a PPI contributor to get in a slot in the meeting and to speak, and even harder in the moment to kind of formulate focused questions so that they come out clearly. And it just requires a lot of effort, but again, patience on the part of the team. In terms of the benefits, again, I'm going to speak about the benefits to me, but they are massive and many. So obviously being involved in really interesting and important work. And although certainly in the clinical research facility, Joe and I, our role is minimal, but we feel as though we are part of really important work. And we always speak about and ask questions in every meeting. We learn lots of new things, and we have this sense of making a contribution, and that it matters lifelong, but particularly now for me, I'm someone who's retired, so it just feels as though I may hopefully be doing stuff that is useful to other people. Thank you.
Brilliant. Thank you both.
Thank
That
you
was really
both.
good.
I'm just going to, I've only just realized that there was a question here that was posed a few minutes ago. You mentioned trust as a possible barrier to underrepresented groups getting involved in PPI. Are there any other reasons you've identified, and how can those barriers be overcome? So I think that's quite a nice lead in after the public contributors' perspectives.
Yeah. And I don't know if anybody else on the call wants to say anything, but I think also a lot depends on which underserved community it is. So we talked earlier about the research ambassadors, and they've come from been recruited from global majority communities. But we are setting up a new research ambassadors project with an organisation called Inclusion Gloucester, which is a disability charity, and it works with people with both physical and learning disabilities and neurodiversity. So we'll be creating an ambassador that's recruited from those communities, or a couple of ambassadors from those communities that we that we work with to overcome those difficulties. But there are also some really pragmatic things. I remember sort of setting up a workshop, and Louise Ting, who developed the research cycle thing that you saw earlier, she's one of our public contributors locally. And just to say that diagram has been used throughout the country and further afield. I think there's even researchers from Australia who've started using it, so it's had a big impact. But one of the things I always remember Louise saying, because Louise, and she won't mind me saying this because she said it in public before, that she's neurodiverse. So she just admired, when you set this workshop up, just make sure that there's fidget spinners on the table for people to play with. And it was just a really small thing, well, not difficult to do, but it made such a big impact having that just helped again to make things a little bit more accessible. I remember once doing a workshop with people who'd got dementia, relatively mild dementia. But one of the things that somebody advised us to do was to make sure that the agendas as well are on the table. Maybe the agenda is put upon the walls, so that if people lose their place in where they are in the agenda because of their memory difficulties, they don't have to keep putting their hand up and ask. And if they can't see a paper agenda on the table for some reason because they've lost it or someone's moved it, it's on the wall, and it just makes that meeting far more accessible. So anyway, these are just a couple of anecdotes from me, but I think there are a whole range of practical things which sometimes aren't massively expensive or difficult to do, but it is just having that input from public contributors to help you have these insights to make these things more accessible, both in practical terms, but also creating that safe space. But I don't know if Adele and Kathy and Pfizer want to add anything.
I'm not sure that I do. It's just that I've taken on board what you're saying about dementia. I worked in dementia cafes alongside people there, and that was a very positive environment to get involved with. And like you were saying about building up the trust, it isn't just the zoom in for one visit. You've got to work alongside people or get to know them as well. And that, I found it a very positive experience.
I was just sorry.
No. I was just going to. There's another question about young people, but we'll come to that in a minute after you've said your bit, Kathy.
I was just going to say that in terms of trust, on the senior management and prioritization group, they sometimes meet us for coffee away from the building and the setting, so it enables us to ask any questions at all, and so that's just helpful to us and building of trust.
And there's a question there about young people. So two things to say there. We're lucky in Bristol. We've got a young people's advisory group which has 101 members as of today, and they range. The youngest ones 10, and the oldest ones are sort of 21, 22, and they've been involved in a range of research projects. There's a research project they initiated themselves, which was looking at the use of isolation in schools as a means of maintaining discipline and the negatives of that, and they explored the negatives of that, and then also developing alternative strategies for teachers to use. So that's at one end of the scale. I'm involved in a project which is looking at surgical operations on young children, and there's two ways of doing a particular operation. And we're going to work with young people and their parents to design that piece of research, basically to look at the pros and cons of two different ways of doing a particular operation on people's tummies, children's tummies. But yes, the other thing about the Young People's Advisory Group, we did a little survey just to check on its diversity, and it is a diverse group. There's about 101 of them, and Lucy Condon, who runs that, maybe we can pop her email address in the chat for anybody that's interested. But she's running workshops, and again, because we've moved online for a lot of this, a lot of the workshops with the young people are online and done on relatively quick notice. In fact, there was one last night which was initiated by UK HSA on Thursday in results in result in as a consequence of the I think is it meningitis outbreak that's happening, and they wanted to talk to young people very quickly about vaccinations. So literally, UK HSA said that on Thursday as a result of what we've all seen in the news, and by last night, Lucy was running a workshop on that for UKHSA with young people, um, which I think just shows how amazing Lucy is, really. Um, um, so I've got with some more questions. Ashley's got one about um, resources and things. Kathy is going to create a website where all these resources are going to be collected. And that will be produced, and that website hopefully will go live in the next few weeks, and we can make sure that I think, but one thing we might have to do, Kathy, is just once it does go live, is email the link to everybody on the emailing list so they've got it.
Absolutely, we will have a bit of a soft launch of it, and there's quite a large section on co-production, actually, seeing as you're specifically asking about co-production. People in Health West of England do actually run a co-production workshop, which took place earlier this month, which has very limited number of spaces. So we do run it twice a year. This is done with our colleagues in the Applied Research Collaboration West, whose funding is now being finished. So we're not quite sure how that's going to be run in future. But if you are University of Bristol based, the Bristol Medical School does actually run short courses on co-production. They are free for university staff and students. There is a small-ish fee to pay. I think it's around £200 or so for people outside of the university, but I can include links to all of that in the debrief after this workshop, after this session.
Brilliant. Should we move on to the next slide then?
I was just going to say the one question, the public contributors here seem to have been involved in lots of different research subjects. Could they say something about that, because it sounds difficult and intimidating? Is it not sometimes difficult to understand and keep up?
May I start in responding to that?
Go ahead, Kathy.
I'm sorry, my neighbour's drilling. I hope that's not distracting for you. I'm only ever involved in one project at a time, so I'm not trying to balance lots of different things. So when I describe, say, the topics that are brought to the clinical research facility, different topics are brought each month. And so that gives us, as public contributors, chance to just have a think about that, maybe look up a little bit of stuff about that. So it's only over time that I've been involved in several things over the last 2 years. If that doesn't answer your question, then do ask a supplementary one. Thank you.
For me, I think nearly overridingly tended to only offer where I have lived experience. I have had some things outside that, but it's been more challenging when things are more formal, say board level. And I've heard the same thing. I think Kathy said the same thing. So what's been helpful was pre-meet was what helped me to cope with that, so that you can sort of head things off at the pass. And then you've got a channel open. If you've had something that's cropped up during the meeting, you can get back to somebody. So it's the support that's invaluable for that sort of thing. But yeah, lived experience just makes it all easier to deal with. The biggest challenge was the genomics, because I'm not a scientist at all, and that's hugely challenging. But they helped you to make it positive experience and to be genuinely helpful.
Thank you both. I'll leave it back to Andy.
And just to say, Adele, only 'cause it's recently, but we've just submitted in the last week or so a new bid, which is going to be looking at how we can involve the members of the public in genome-wide association studies. So they're the things where you look at, and usually we're not talking about a gene, we're talking about hundreds or thousands of genes and how they influence, together with environment and a load of other factors, complex behavior, like things like your experience of anxiety and depression and things like that. But one of the things we'll be doing is looking at what's called something that's called Manhattan plots, which are the way that they look a bit like bar charts, but it tells you which genes are affecting what. We're going to do a public involvement training for that. So hopefully if we get funded.
Excellent. This is the next step. Again, it's just seeing that whole development over my lifetime. It's fantastic.
Yeah.
Good to hear.
And Pfizer, do you want to say anything about this or the hard to reach, issues to do with reaching underserved communities?
I have written something in response to that question. It's just saying, having more connections before the project and, invest some time to build those connections with the communities can, help improving the interest of those communities to the researchers and the organization and institutions.
Yeah. I think that's really important because I think in the past, researchers have got a really bad reputation with some underserved communities because researchers tend to do a kind of smash and grab thing. They turn up, they're very interested for a year or 2 years or whatever, and then the project finishes and they disappear or falls apart.
Yeah.
Thank you, Pfizer. That's a really good point. Okay, should we move on to the next slide? So yes, we're going to talk about facilitation and co-facilitation. So again, this is quite a big topic. It's one of the things I think that a lot of people get nervous about if they've never done before, because I think people worry about what happens if I say something wrong or upset people, and how do I cope with all that? And it's a whole topic in itself. And we have another session which is just on facilitation. But we tried to touch in the introduction on all these things to at least at a light touch level. And this particular slide is just a brief summary of some of the roles that you have to play when you're facilitating a workshop or a public involvement session. So sometimes you're there to provide some leadership or some focus. Quite often some discussions can get quite lively, I mean in a positive way, but because people are interested and engaged, the discussion can go quite wide. Sometimes that's really good because it ensures sometimes it brings up topics you wouldn't have predicted and turn out to be really, really relevant. But there are times when you just need to think, we need to bring this back to what we need to do for this particular research project. And sometimes you want to make sure as well that all the voices are heard. And there are some people who are very, as you can imagine, in any group, there's some people who are very vocal and other people who might have got a lot to say but are very shy. So that kind of brings you to the kind of referee role where you're just making sure that everybody is getting a voice and thinking of ways perhaps to encourage people to contribute who may have been saying less. And it's really important that you do that. If you've got a workshop and let's say there's 10 people in it and there's 1 or maybe 2 people that are really dominating, you might try to suggest that they speak a little bit less, quite gently, but if they don't, you might have to be quite assertive. I know some people get worried about that because they don't want to upset people, but my rule is if you're thinking that, then the other 8 or 9 people in the workshop are probably also feeling fed up because they're not getting a chance to say anything because someone's talking all the time. So you not doing anything, particularly if you're doing it because you're worried about upsetting that person, runs the risk of not upsetting one person but upsetting 9 other people. And you've got to think about what's the best for the group. It doesn't happen that often, but I always think this is not about that individual. It's about the group and the benefits to them and the research project. And also, I sometimes go to some events, and I don't know what Adele and Kathy think, but sometimes I just think people just overdo the facilitation. Sometimes conversations are happening quite nicely, and people are talking, and all you need to do just to keep the process running. Um, and you don't need to do lots, and you don't have to have structured activities and things. You can just let people talk. Sometimes, I don't know, yeah, maybe it's a matter of taste, but there's times when I've been in some workshops where I found some of the activities slightly patronizing. But again, Adele and Kathy, have you ever come across that? Have you ever felt the thing that balance between over facilitating and facilitating well?
I was just thinking of a meeting recently that I went to where there was one uh, over contributor, and I think handling it is incredibly difficult. And obviously, it depends on the relationship between the chairperson and the person who's over contributing. Although sometimes, if they are known to each other, that person is maybe over contributing because they know the chairperson and the people running the meeting. So I think the dynamics are really important, but very hard to balance. I absolutely agree about if one person is over contributing, other members are likely to be feeling disheartened by that. And yes, thank you.
Thank you. Thank you, Kathy.
I'm just filled with people who do facilitate. I've had a bash at it, and it's not my strength. And I've the best chairing I've ever come across was within IHR, and it really was. I don't know whether they have a particular training, but I just take my hat off to people that do it. One of the things that I find most frustrating on the receiving end is managing the time when an agenda gets hijacked. To me, that's the worst thing ever, when you haven't got through everything or it's gone off course and you've not really got the things sorted that you wanted to get sorted in the meeting. So I just have nothing but admiration for the people who are facilitating.
Great. Thank you. Faiz, did you want to add anything?
Sorry. Not really, but I can yeah, I can relate to one of the my recent meetings where I was a facilitator and there was a person who was over contributing. And the thing was that he was really, really knowledgeable and contributing really well and has much more information around the structure of the the whole thing which was under discussion. But it was really hard, you know, to manage that meeting in terms of, the other peoples are not contributing and one person is over contributing and, who is professional and knowledgeable and contributing well. But in that case, I think it's best approach to create some additional questions from their conversation and ask other people and invite other people to give their perspective on those. But yeah, it gets sometimes challenging. And I think there should be some sort of training or on that for the public contributors. The public contributors would know that we have to we have to stick on the agenda and give other people chances to speak as well.
Great. Thank you, Faiza. Should we move on to the next slide then?
I was going to suggest that maybe we wanted to talk about the publishing PPI work question before we round up.
Yep. So just to say on that one, there are 3 journals that are dedicated to publishing things in the PPI world. So one of them is called Research Involvement and Engagement, and that's dedicated to publishing PPI papers. There's a second one called Health Expectations, which publishes a range of kinds of academic papers, but really welcomes papers on PPI. And there's also one called Research for All. So there's 3 dedicated ones. Sometimes you'll find with journals, if you want to write a paper about some PPI that you've done and what you learned from it and so on, um, then then um, then they'll say to you, have you got ethical approval? Because we won't publish something because it's not ethical approval and this is about research. Um, so some journal, the dedicated ones, the editors won't say that because they understand it, or usually won't say that because they understand it. Other journals where you might want to publish it, you might get that question. There is a statement from the Health Research Authority which clearly states that you don't need ethical approval to do PPI. So I've found if there's an argument, sending that to the editor helps. And the thing about it can be attractive to publish PPI papers in those three journals that I've just mentioned. But also one of the difficulties with that is that they obviously, well, the positive is they welcome PPI papers, but I also feel a little bit like if I publish stuff there, the people who read that are always the people who are already converted to PPI. So you're kind of talking to people that you already know. So I think it is worth trying to get PPI papers published in other journals that wouldn't normally have that, to try and say, well, look, you can do PPI in all sorts of different kinds of research. So I just mentioned that thing about genome-wide association studies. We did a little look, and we couldn't find one genome-wide association study that had PPI in it ever. And the most we could find was that some people had written FAQs, frequently asked questions, that were meant to be public facing explanations of their research. But even those were written by researchers. We couldn't find any that had been written by members of the public. So I think actually if we do that, we get funded and we do this piece of work, it would be a really good idea to get it published in a journal that focuses on genome-wide association studies, because it'll have more impact in that journal than it will do if it goes in one of the PPI journals where you're talking to the already converted, as it were. So I think those are the things that are worth thinking about. I think someone said in the chat that I'll type the names in, or Kathy's actually on the case already, so Kathy's going to do that. Knowing Kathy, she'll probably give you the links to the sites as well because she's so super efficient and quick. And I'd be hands and fingers and thumbs trying to just type the title, never mind get the link as well. But there you go. That's why we've got the super Kathy. That's helpful on that particular question. So this is just to start rounding up, really. You've already mentioned People in Health West of England. As you've gathered, we've got a mailing list of 450 odd people on it. They're public contributors and people who are kind of PPI leads. And Kathy regularly sends out invitations to get involved in research projects on there. So if you're interested as a public contributor to find out about those things, it's well worth going on there. As you've heard Adele and others describe, a very wide range of opportunities there. But also, if you're a person leading public involvement, it's a good place for you to send your PPI advert or opportunity to get people involved. As I say, it's got a good, normally when we send this stuff out, we get responses back within sort of 48 hours. Adele.
It's just occurred to me, we haven't mentioned the research conversations. Are they continuing? Because they are also valuable ways of contacting people and broadening when people are shaping up a project.
Yes, I think that the health. Sorry, for people who don't know, there's a thing called the Applied Research Collaboration that's helped fund some of this PPI work, and it sadly hasn't had its funding renewed, so it's going to come to an end at the end of this month. But there is also a thing called Health Protection Research Unit, which is going to keep some of these things running. And Adele, you're part of the health, as well as being part of the ARC, you're also part of the Health Protection Research Unit. Do you want to just briefly say what the conversations are?
Yeah, they happen at a variety of times so that you can work. Sometimes, people who work and we've got one this week and it's between 5 and 6. So it's an hour. And it's an opportunity largely that what happens is the researcher comes along, talks about their project, and then they're seeking patient and public opinions about what they're doing to help them shape it up further. And sometimes people carry on with it. You can express an interest and go on with it. So it helps them also perhaps to engage with people for advisory groups and things like that. And wide, massive variety of topics. This particular week it is on dementia, so I shall be in the front row. But there are no barriers; anybody can go along. But it's also an opportunity, an informal opportunity for researchers to get a wider input.
Thank you, Ken. Thank you. And Joe said, is there much contribution for PPI? Oh, much competition. I was wondering, so is there much competition for these things? So I think,
I don't think so.
no, I mean, sometimes when we send, yes, that's right. What Catherine's just said, that the recruitment for them tends to vary. Quite often, the key issue is trying to create. Because it's not really about applying for a job. You can't really necessarily say one public contributor is better than another, apart from have they got the right lived experience, obviously. But the other key thing is trying to gain a range of perspectives, so it's not all just stereotypically white middle class retired people. That I think there are issues like that. I'll just quickly, because we're coming towards the end, I'll just quickly finish off with this slide. So and again, Kathy's been key to this, developing a PPI community of practice across the west of England, which we want to do. So bringing all sorts of people doing interested in in PPI, both researchers and public contributors, together to work on and solve some of the problems and issues. Obviously, one of the things we want to do is improve people's knowledge, and these training sessions, these learning and development sessions are part of that. Develop people's skills and expertise. We have resources that Kathy's mentioned, and there'll be things like how to calculate a PPI budget on there, information about research ambassadors and co-production and the learning and development program. We can provide advice and guidance, and Pfizer does that, and I do that, and many of the public contributors do that. We've talked about improving diversity, the sharing of resources, and we just want to coordinate the PPI activities, because we're also aware that a lot of people might be doing PPI in their own organisation, and there's a lot of, with the best will in the world, there's perhaps more duplication and more reinventing the wheel than there needs to be, and people could, if there's more working together, we'll develop better solutions to problems if we work together, and B, we'll get those solutions out to a wider group of people more quickly if we have a network that enables us as to do that. So that's a little bit about people in Health West of England. I don't know if anybody else wants to add anything, but yes, if you want to join the mailing list, then that is the QR code that will allow you to do that. And I think, unless anybody's got anything from the team or what that they want to chip in, there's our contact details.